Okay guys, here we go. Anesthetic emergencies, or what to do when things don't go quite right. So every anesthetic procedure has the potential to cause death. I like to say 80% of the time it's pretty darn boring, but that other 20% can be terrifying. So in order to prevent that 20% terrifying, you must be vigilant and you must be prepared. So you need to be familiar with the things that can happen, why they may happen, and what risk factors exist so that you can help to prevent this. And then, of course, when these things do happen, what you can do to try to fix it. So constant vigilance. Even though it's really easy to want to get wrapped up in your Sudoku or whatever you're doing, you have to always pay attention. It's amazing how quickly things can shift and go downhill. So there are 4 main reasons for anesthetic emergencies: human error, and then equipment issues, adverse effects of anesthetic agents, and patient factors. So those are the ones that you hopefully can control a little bit more or prevent. So human error, the biggest thing is probably being in a rush. You don't get an adequate history, so you might miss those little details that could tell you something really important. You don't do a full physical exam, or someone doesn't do a full physical, so then you miss an underlying issue. Or, we've been noticing cats with respiratory issues. They may have been fine 2 days ago, but now they're all snotty, which means they're not a great anesthetic candidate. Inexperience with the anesthetic machine. So this will be probably your first hurdle because you're not super familiar. So it's really important that you spend time getting to know your machines. Failure to devote sufficient time to the patient, paying attention to what is going on with your patient. Fatigue. We all know when we're tired, we make mistakes. Failure to recognize early signs. That's why we have that sheet, so you can track things. So when you start noticing things going downhill, you can turn them around before they get really bad. And your failure to evaluate your patient parameters. So you're not doing your checks routinely, or you're not doing all of your checks, so you start missing things. So why do people fail to obtain a history or perform a PE? Pretty much everyone's busy, running around. Somebody who doesn't know the animal drops the patient off and doesn't have any information. Untrained staff may neglect to ask really good questions. I hope no one ever forgets, but my guess is it's usually rushing around. And they just do a quick physical, a quick PE, because there's just so much else going on. You've got appointments back to back to back. So the problem is you're missing important information. For example, the patient wasn't fasted, or the patient's been vomiting all night, or, this patient's had diarrhea for the past week. Anesthetic protocols that are safe for your normal, healthy patients can suddenly become dangerous, or anesthesia itself can become dangerous when you miss these details. Boom. Inexperience with the anesthesia machine or agents. So we're trying to teach you guys how the machine works. We're showing you different configurations, but depending on the clinic you end up at, they may have something different. And the characteristics of different kinds of anesthetic agents. There are all sorts of different kinds of protocols. Some have different strengths and weaknesses. It is up to you to be familiar with drugs and with machines. It's up to you to spend time learning how to work the machine at your new practice. Especially those first week when you're just kind of wandering around, take your time, go look at their machines, see how they go together, do some leak tests, make sure you understand what all the bells and whistles are, or what bells and whistles you're used to that are missing. Also, it's a good time to start looking at their routine drug protocols and make sure you understand their protocols. Maybe eventually you find something you'll like better and you can start using that, but you need to know what they're doing, what they have, etc. So here are 2 different kinds of machines. They both work the same, but definitely laid out differently. So incorrect administration of drugs. How can this happen? Weight. You're not able to get a weight, or the weight is incorrect. The dog is way too squirmy, you forget to weigh it, whatever. Mathematical error. This one, you need to get really familiar with what looks right and what looks wrong. Way too often, the decimal place ends up in the wrong spot, and you guys have probably started to realize that you never give an animal 1.0 cc's or even 0.1 cc's of acepromazine. We've never done that with any of our cats or beagles, maybe a bigger dog. But if you start getting big numbers of acepromazine, you may need to look at your numbers again. Wrong medication, wrong concentration. Most of the time, this is because people are not reading labels or reading them correctly, okay? They grab the wrong thing, the colors are the same, etc. So it's up to you. We always used to say you have to do 3 checks: when you draw it up, after you draw it up, and before you give. So this shows you a quick drug safety therapeutic index. So for example, how much you can give for effect, where the toxic effect and where the toxic effect shows up. Anesthetic drugs have a very narrow margin of safety. There's lots of drugs you can give 10 times the dose and they're fine. That will not be your case here. You will end up with really big problems really fast. So failure to devote time and attention to the patient. You may be running all over the place, trying to work different rooms, working with different vets, etc. But at the end of the day, it's up to you to make sure those patients under anesthesia are your top priority, okay? It is common for the anesthetist to occasionally have to leave the patient. Maybe you're the only scrub nurse as well, or generally a circulation nurse, so you have to run, get something. But you need to make sure that every 5 minutes you are checking those reflexes and heart rate, etc., and that you stay as close as possible to the patient to help as needed. In lab, we told you never leave your patient unattended. I don't even want you going to the other side of the room unless you've tagged in with somebody else. Fatigue. So this is a very big problem. You may not even realize it's happening. It can slow you down. You miss things. You're not paying attention. So if this is the case, ideally when you're scheduling, you want to do your lengthy or difficult surgeries where you really have to be on your toes first. If you have a simple neuter, that can be done when you're, not that you want to pay any less attention, but a short neuter is not going to wear you out the same way a 2-hour TPLO surgery will. So failure to recognize early warning signs and evaluate your patient parameters. So it's always better and easier to prevent problems than to fix them. Ounce of prevention, pound of cure. So for example, anesthetic depth. You start noticing that rest breaks are starting to drop. So what can you do? You can turn down your gas. Keep turn so that one. Then if you have to, turn off your gas, because otherwise you may end up with cardiac arrest. Equipment issues. This hopefully you've taken care of during your systems check. But if not, or if somebody else checked the machine, it's always still a good idea you go back and check your own machine. But sometimes you're tagging into a surgery, a long one that's going on. So things that can happen. Your CO2 absorber is exhausted, your oxygen empties, the anesthesia machine's put together incorrectly, endotracheal tube problems, vaporizer issues, and pop-off valve problems. So your CO2 absorber, as you know, is supposed to absorb carbon dioxide, which is toxic at high levels. Hypercapnia, that is when the blood CO2 starts to increase. You can see this clinically, usually by tachypnea or panting. That's one of the reasons we pant, or well, we don't, but animals pant, is to blow off extra CO2. Tachycardia, so an increased heart rate, and arrhythmias. So remember, sometimes that canister may not show much of a color change, or it may be very muted, so that's why you can do the crushed chest as well. If you suspect this is a problem, obviously you change the CO2 canister at once. Empty oxygen tank. Hopefully you've checked your oxygen before you started. Make sure you keep an eye on your flow meter. If it's nice and smooth, you're good. All of a sudden you'll notice that it'll slowly decrease or maybe even start bouncing a little bit. Turning up the flow meter as this happens will compensate for a while until you get rid of it. If this is the problem, then you actually need to disconnect the patient and give them room air. Okay, so just having them so as long as they're breathing on their own, having their tube just connected to the air. Obviously, they won't be getting any ISO at this point, but the best case is to just not let this happen. Machine misassembly. So again, knowing your machine will prevent all this. Making sure you know all the parts, how they work together. Trace the flow of oxygen. That makes sure you know that the patient is actually getting the oxygen and the gas and isn't rebreathing expired CO2, or that's properly being circulated through the absorber and back to the patient. Otherwise, Endotracheal tube problems. So tubes can become kinked or blocked with fluids, mucus, etc. They're blocked, they're not getting oxygen. Nothing's going in, nothing's coming out. Patient signs, dyspneic, they'll start having difficulty breathing, cardiac arrhythmias, respiratory arrest. Because don't forget, they're also not getting rid of CO2. That's building up as well. Action, check your ET tube. Give it a breath. If it's blocked, you will feel resistance and the chest won't move. You can disconnect from the machine and feel for air from the tube with a breath. If it's blocked, you need to reintubate. You can mask if you need to. You can try to suction the tube with a 20 ml syringe and red rubber if it's fluids, and then just reintubate. Vaporizer, using the wrong vaporizer. That wouldn't be a good idea. A tipped vaporizer, making sure things aren't leaking. If it leaks into the oxygen channel, they can overdose. Have you smelled that stuff? It's pretty potent. The dial gets stuck. Do not use the machine. You don't know how much they are or not getting. There are 2 vaporizers connected in series. Make sure they aren't both on. That's one right after the other, because then they'll be getting a double dose. And don't overfill your vaporizer. Pop-off valve closed. Most of you saw when I did a pressure test, I showed you how quickly the manometer went up with the pop-off valve closed. This means the patient's lungs are full, they can't exhale, decreased venous return, decreased cardiac output, blood pressure falls rapidly, and they die very quickly. So easy fix, simply just open the pop-off valve. Monitor the rebreathing bag, make sure it's only 2/3 of the way full. You may need to change the flow rate, but at the end of the day, you open the pop-off valve and that should fix everything. This shouldn't be an issue if you did your leak test properly, and also just make sure when you give breaths that you always reopen it if it doesn't have one of those little easy push buttons. Adverse effects of anesthetic agents. So this is about knowing your drug. Make sure that you don't just use your the one standard protocol. Make sure it fits your patient. Be familiar with the drugs you have available and use multi-drug protocols. You can use less of each drug, which will minimize the side effects. So as opposed to just one whopping dose, you can do 2 smaller doses of drugs that complement themselves. So here's some things to consider. ACE, you don't want with patients with hypotension. Halothane, avoid in cardiac arrhythmias, and alpha-2s can cause fearfulness or excitement. So if you have bradycardia, arrhythmias, vomiting already. Okay, patient factors. So these are the different things that the patient will present to you. So geriatrics, this is an animal that has lived 75% of its life expectancy. So a 12-year-old animal is considered geriatric after age 8. Their organ function can be reduced. They have a poor response to stress. They may have disorders that you do or do not know about, so it's really important that you do preoperative testing, history, and physical exam. They have reduced anesthetic requirements, slower response to drugs, may take them longer to recover. Hypothermia is a big issue, and IV fluids are important in all cases to support their organs and blood pressure.